working groups. You'll get instructions, and I think better instructions today, and people to follow to lead you to the discussion group and to where you can meet for an hour and a half on the workshop. We'll come together, if I'm not wrong, at 4 o'clock here. You can for a number of capacity building workshops. So please consult your program. You can choose where you want to go. There are many themes that are going to run. In this room, we'll do a debrief on the network method. So that could be interesting for those who are first comers. But all the other subjects are very interesting. So please take a look, read the script. If you have questions, do approach the Secretariat so we can give you more information, and then you can make up your mind where you go. Tonight, we have a very important event. There is a reception that will showcase Ethiopia. Ethiopia has prepared a number of case studies that they wanted to share with us. Agenda is packed, so that sharing will happen tonight during the reception. I understand there may be some music, so I hope there will be music, but it's not only about the music and the meeting, but do pay attention to what Ethiopia is bringing forward. I think there will be more information coming forward. Any last moment? No. Okay, thank you very much.
Thank you, Bletta. Can we put our hands together for her? Okay, so as you can see, we are supposed to start exactly at 8:30, and we're already behind time. So I just want to find out if my colleague who is co-chairing with me from Uganda is here to join me up. Uganda? Okay, so I'm left alone, so I'll manage it. All right, so the session description. Basically, this session is going to explore the systems required to sustain efforts to improve quality of care for maternal, newborn, and child health in countries, and specifically focus on what we are learning about how to provide on-site support for countries' quality improvement initiatives that are going on. So we are going to have a 1-hour session, but as I said, we are already behind time. So quickly, I will invite Nigel to join me up here, and then also invite the 3 countries that are presenting, Ghana, Nigeria, and Sierra Leone. Nigel is going to talk to us in just some 3 minutes, and then each of the countries is going to make a presentation of not more than 8 minutes. In fact, I will stop you as soon as time. Otherwise, I'm going to lose time. So Nigel, please take over.
Thanks. Yeah, I just wanted to do a quick introduction and clarify a couple things from yesterday. Okay, so we have a shared goal. We want a 50% reduction in mortality. We want to make sure that the facilities have the right staff that are enabled to deliver the right care in the right way at the right time. There are a variety of policies in the countries to guide how that will happen, and countries have picked a variety of different quality interventions at the system level, at the facility level, and at the community level to try and make sure that this happens. But there is a big gap between deciding how care should improve at the facility and actually making it happen. So projects solve that gap by setting up parallel structures and systems outside of the existing systems. And they often engage ministry staff, but they engage them within these parallel structures. And that is not sustainable. As soon as the project goes, these parallel structures disappear, and the skills that you might learn from working inside a parallel structure aren't always transferable back through the existing system. So one of the key goals of the network is to figure out, as 10 countries, how to build structures and systems in the existing institutions in the Ministry of Health to support implementation in a way which is sustainable. So it's working through existing structures, building systems to providing on-site support learning between facilities, improve measurement around quality of care, engage communities, and to do better program management from all levels of the system, so that this is something that can be continued indefinitely. And so we're going to be talking for the next 2 days about 4 of these systems in depth: on-site support, learning, measurement, and program management. At another time, we talk more about community stuff. So we're going to start by talking about on-site support. And again, we're interested in on-site support mechanisms that can be used to continually build and maintain skills in people at the facility level. All right? They can be used for a variety of skills. We're going to focus today on skills around quality improvement. Okay? Most of the countries have decided to use some quality improvement methods, which is great. They're a good way of instilling problem-solving methods into the facility level and throughout the whole system. But these are skills that we don't build from the beginning. I don't think any country builds these in pre-service training. So we have some challenges. We need to figure out how to do this in a sustainable way. Not a project coming in with an outside method and training a few people repeatedly and working with coaches, but how a country can do this in a sustainable way. And let me just be precise about what we're talking about with QI skills, okay? Every country has a different model or a different training material, but we're talking about things that focus on teams at facilities, working together using various tools to analyze system problems, using iterative cycles to test and then adapt possible solutions, using PDSA cycles or something else, and using frequent measurement to guide decisions. That's what we're talking about. And so the purpose of today is to share between the countries what QI approaches they're using and what training materials they have for those, how they are building the skills around quality improvement in the system, and how they are providing on-site support to help people in facilities learn QI skills and apply QI skills, and what are the challenges at the national, district, and facility level. And then to find out what's happening now, but a lot of what is happening now is in projects, so we really want to learn how that is being transferred into government systems in a way that is going to be sustainable. So we'll start with the plenary, and then we'll have group work with more guided discussions around this topic.
Thank you very much, Nigel. So we'll quickly move on. He talked about the objectives and all that. So I think, Zainab, are you ready? Ghana? So we invite Ghana to do a quick presentation, but as I said, it's not going to go more than 8 minutes. So when it's 5 minutes, I'm going to signal you. Okay. The black one. Yeah.
Good morning, ladies and gentlemen. I'm grateful for the opportunity to present some work that we have done in Volta region, one of the administrative regions in Ghana. We look at how we will improve maternal, neonatal, child health indicators in our region. Next slide. In 2017, as a region, we noticed that some of our indicators, particularly maternal and child health indicators, have not been too good. We recorded 71 maternal deaths, 193 neonatal deaths, 347 under 5 deaths, 630 infant deaths, and 829 stillbirths. Additionally, Ghana, at the end of each year, Ghana has published a league table. 2017, we were last on that league table as a region. So we were very dissatisfied with that situation, and we took certain steps to reverse that trend. So as a region, we set for ourselves to improve maternal and child health services across the entire region. And specifically, we look at reducing institutional maternal mortality by 50%, neonatal mortality by 30%, and stillbirth by 50%. We have 25 districts in the region, so we couldn't work in all these districts because of resource limitation. So we prioritize 6 districts. Yes. In this district, please go back. Go back again. Yeah. In these districts, we did some analysis. We reviewed data and look at some of their reports. And we realized that in 2016, 32 maternal deaths were recorded in these 6 districts alone. 75 neonatal deaths, 295 stillbirths, and 103 infant deaths, including 295 under 5 mortalities. So using Pareto principle, we prioritize these 6 districts according to the indicators that we are looking for. So having analyzed their data using flow charts, in-depth problem analysis, we came up with some specific issues that we need to work on. We have noted varied degrees of knowledge in managing newborns and obstetric care, inadequate monitoring of mothers and newborns, inappropriate medication regimen for neonates. The referral system was not very robust in these 6 districts, and inadequate clinical guidelines in management of cases. Pathographs use was a serious challenge in these districts, and inadequate skills of neonatal resuscitation. So this is a picture indicating the problem analysis sessions in the district. So we plan some interventions. We carry out biannually 5 specialist outreach visits. In the region, we have only 3 obstetric ONG specialists and 1 pediatrician. 2 of these obstetricians are located in the regional hospital. So the rest of the districts, the 25 districts, do not have access to specialty care when it comes to maternal and child health. So we organize specialty outreach visits to this district to coach and mentor the doctors who are working there, including the midwives. We also organize learning sessions for the 6 districts to share experiences in the work that they are doing. We conducted maternal audits and maternal peer review in the 6 districts, and we train midwives in the appropriate use of pathograph. We focus on coverage, that is those who are eligible for pathograph, where they actually put on pathograph, and we will also look at the completeness and adherence. We emphasize adherence because coverage and completeness do not necessarily translate to the desirable results. The adherence means that the decision that you take for the mother or the woman, the interventions that you have done are in line with information that you have gathered for the pathograph. We also train midwives and nurses to conduct audits on the care that they provide. Yes. So the specialists I mentioned, they visited the sites, the 6 districts that you have shown. You can see the trainees, some of the specialists taking the medical officers through basic surgical procedures. And then we teach. They also conducted ward rounds in the pediatric ward, the neonatal care units, and then the maternity unit to teach the doctors and then the specialists basic procedures and how to diagnose and how to prescribe the appropriate regimen for the client. We, as I said, we also look at pathograph use in these facilities, and we look at 3 main dimensions, as I've mentioned: coverage, completeness, and adherence. One critical thing we also look at is data. We realized that in this district, the data quality was very compromised. So we organized monthly data review for all the facilities at the sites to review their data. This is a picture of some of the data review sessions. So what did we see after doing all these things? The baseline before we started for maternal mortality was 269. And by the end of 2017, we have been able to reduce it to 117. Our target was 180 per 100,000 live births. By the end of 2018, that's the project life, we have reduced it to 83.2 per 100,000 live births. That has significantly impacted on the regional performance. You could see as a region, we were at 148 per 100,000 live births. In 2017, by the end, we reduced it to 126.2 per 100,000 live births. And at the end of 2017, we were at 76 per 100,000 live births. Initially, we saw a sharp increase in neonatal mortality. This was as a result of the fact that some of the diseases were not being documented. So as we started working on the data, the data reviews, we have seen more cases, more deaths that have not been actually entered into the DIMS. So that has accounted for the initial increase in the neonatal mortality. But at the end of the project period, we have been able to see significant improvement that brought it to 4.9. Stillbirth, we have done very well as a region. And we have brought it finally to, at the end of the project life, that is 2018 to 1.0 per 1,000 live births. That has also impacted significantly on the regional performance that has been brought to this. So the summary of the changes that we have seen over the period were as follows. Maternal mortality in the projects are reduced from 32 to 9. Stillbirth reduced from 295 to 191. And in the 6 project districts. And as I said earlier on, that has made a significant impact on the performance of the region. Stillbirth similarly has seen a significant reduction, as I mentioned earlier. Yes. Pantograph adherence, we were not looking at completion and coverage, we were looking at adherence. Also improved from 39.9% to 53.8% in December. However, as I said, neonatal mortality has seen initial increase as a result of the data quality that we have addressed. So what were the lessons that we learned? We realized that commitment of leadership was key to any successful quality improvement strategy. Shared learning also contributed significantly to the achievement that we have seen. We were able to build teams that were able to work together. And then giving staff the necessary skill is also necessary in any quality improvement endeavor. We will continue to scale up to the remaining districts in the region. Thank you for your attention.
Thank you very much. So, unfortunately, he used 10 minutes. I don't want people to say that because he's from Ghana, because I know, yeah. Anyway, so Nigeria, can you take it up quickly, and then we can move on. Save your questions. We're going to discuss that, during the part 3.
Mr. Chairman, permit me to stand on existing protocol. Good morning, everybody. I'm Dr. Hussein. I come from Nigeria, Cross River State, specifically South State in Nigeria, where we are implementing the program to reduce, through quality improvement, reduce maternal and infant deaths in our country. When the program started, the Cross River State Ministry of Health, through the support of the federal government, had in collaboration been working with Pathfinder International and other NGOs, the World Health Organization. We're also working with MEC for Mothers and the University of Calabar Teaching Hospital. Those are the other, partners we are working with. So when we started the project, first and foremost, we identified certain challenges by doing facility assessment. We first of all assessed about 812 facilities, and then narrowed it down to about 107 facilities, which we are going to work on. So we are working on 107 facilities across the state, carefully chosen through the high burden sites and also the WHO model. The on-site mentoring scheme for maternal and newborn health in Cross River State, the Cross River State experience, already mentioned this. We started with a high mortality, maternal mortality ratio of 872. That was what was found in the 812 facilities. And the neonatal mortality rate of 160. We were not happy with this, so we had to go on to ensure that these indices are brought down to the barest minimum. Like I earlier said, we worked on 107 facilities carefully chosen across the states. And from the facility assessment, we discovered there were very many things that were very low. The newborn for instance, we saw that only about 4.4% of the facilities could have ventilation bags. Neonatal resuscitation was very low, and the rest of the indices were quite bad. Cesarean section, only 9.9 of them had the capacity to carry a cesarean section. And we went ahead. What you have there is the map of Cross River State showing you the 10, clusters within which we worked. After all this, we now sat down and looked at the quality improvement approaches. Which are these quality improvement approaches we used? One was capacity building for different cadres of the frontline caregivers, including doctors, nurses, laboratory scientists and technicians, pharmacy technicians. They were trained on emergency obstetric and newborn care, post-abortion care, emergency neonatal care course, and family planning. We also did that through clinical mentoring through the volunteer obstetric care scheme and the volunteer pediatric care scheme. Then these schemes are a collaboration between the state government and the SOGON, which is an association of obstetricians, and we also did it through the volunteer midwife volunteer scheme. There were innovative tools that were used for quality care. These were mother care card, the newborn and the maternal mentorship app, which was used by the mentor midwives. We also established state and facility QI teams, and also MPDSR, the maternal and perinatal death surveillance and response, is a program that is currently going on in Cross River State, which also targets that quality improvement. We also have maternal and perinatal death surveillance response in the state. These are photographs during the training sessions. That's the kangaroo. We also have the VOS, the volunteer obstetrics scheme, and then the volunteer pediatric scheme. In this scheme, the pediatricians, specialists, and the obstetricians move to facilities across the state where they do mentoring. They also give them technical assistance. They actually carry out clinical services in source centers. They also do SMEs with the facilities. They go to such facilities once in 6 weeks. They also carry out on-the-job training, and they support us in the MPDSR. The Mentor Midwives program is a component of the same mentorship program, where we have 28 midwives, experienced and retired, who are used in the various facilities across the state to mentor the midwives in the facilities on the various skills for improving quality of care. They mentor the facility midwives on labor, how to carry out labor, how to do family planning, and they carry out ANC activities. They go to such facilities 4 times in every week. They have allocated facilities to each of the mentor midwives. We also have on the display there is the mentor card and the Concare card. Here is these are some of the results of activities, which I will not permit me to go into details. What are the challenges? We have facility staff attrition. That is one of the greatest problems we are facing, because after training some of these staff, a lot of them leave for greener pastures. Like in our state, in fact, in 2007 and 2008, we had a terrible one where more than half of the doctors in the state moved out to teaching hospital and other places. There is increased workload for these mentors because they are few and the facilities are many. There is inadequate number of volunteers, like I just stated. There is also a challenge of synchronizing these mentorship visits between the pediatrician, the obstetricians, and the Ministry of Health, because the ministry has not yet had direct control over these specialists. That's what we will see when we go to what they are going to do to move on better. Logistic challenges. Cross River State, like you saw in the map, is a very large state. Traveling from one end of the state to the other takes you about 6-7 hours. There is also a sustainability question, which you see how we are going to do that. What have we learned? We have learned that on-site clinical mentoring complements residential training. We also learned that improved maternal and neonatal health outcomes as a result of better coordination among partners, especially the Ministry of Health, which is the coordinating body for all these activities. The imperatives of joint mentorship visit to Sogon and NISOM. Cross River State Minister of Health is to sign, these are our sustainability plans, is to sign an MOU with Sogon and NISOM. What we are already doing is not yet, fully documented. We are also going into, collaboration with the teaching hospital. We are about to sign an MOU where their residents and the consultants will be visiting some of the facilities. In fact, that activity has already started. They have some of the residents and their consultants staying in the facility for an upward of 3 months. After that, another group. In fact, the Anesthetists Association has also joined in that, and that gives us a very good hope. We also advocate for budget and funding because we are afraid of the issue of funding by the time our partners leave. We have gone far in this respect. We have gone far in this respect where the state government now has budgetary subject for these QR activities, including MPDSR, at the facility level, at the state government budget level, and then we also have it in the budget for SMWare. We also have a scale-up plan for these activities to move facilities, because what we are doing is not only within the state government-owned facilities, we are doing it together, or we have cascaded it to the private health facilities. We are also doing it with the faith-based organizations or facilities which are in the state. In conclusion, improved quality of care for MNH increases demand for constitutional delivery services and institutional delivery services. Training, supervision, and mentoring of service providers leads to improved outcomes for mothers and their newborn.
Okay. Thank you. Thank you very much, Nigeria. Can we put our hands together? Okay. So we will move quickly to Sierra Leone. Yeah, please take it.
Thank you very much. Good morning, everyone. Yes, I want to stand on existing protocols. I'm Margaret Mana. I am presenting the Ministry of Health Sierra Leone on behalf of the Ministry of Health and our QI programs that we have been implementing. So for Sierra Leone, actually, before we started, our indicators, we have like, for indicators, we have like maternal mortality that is increasing. On the DHS, you have 1,165, then UN estimate is 1,360. Then we have like newborn mortality is 39 per 1,000 deliveries, then live births. Then we have infants 89 per 1,000. And in a country where we had Ebola, we had almost 4,000 confirmed deaths. You have medical officers like 3 per 100,000 population, and midwives is 50. So it's not even up to the international standard. So we are using a lot of tax shifting, and we saw QI to be one of the key issues that came out from our MDSR reports. So basically, as a goal, we are trying to see how we sustain quality leadership and commitment, then also for us to have optimal resources for improved accountability, and we want to see how best we'll be able to have a sufficient partner collaboration. So the objectives of our on-site support and approach, first of all, we want to see how best we'll be able to establish QI leadership and governance structures at national as well as facility level. Then we want to see how to build a local capacity for quality improvement and how to support districts to see improvements that they can change. So basically, these are the 3 main approaches we use: clinical mentorship, QI coaching, and supportive supervision. For clinical mentorship, we screened and identified competent clinical mentors, and we trained in facilitation and also mentorship skills. Then we developed the tools for clinical mentorship, and we plan for them to be able to conduct regular mentorship. Then for the QI, we developed development of their training and facilitation guide we developed, which we have harmonized with NGO partners. Then there is a national QI focal persons and champions now. Their capacity was built, and each district we have a district QI focal person as well as the facility level. Then the district and facility QI teams have been instituted and established, and we have committees at those levels. Then also in the district, there is a monthly district facility coaching support that we provide. Then for the supportive supervision on MOC and IMNCI, supportive supervision, and also ISSV. So we are now moving towards integration and spreading the change packages that we have started seeing. So the key activities during the on-site supervision, you can see, one, we orient and train them on QI. Then we form QI governance structures at the facility level as well as the district. Then we analyze their situations, the problems they have, and we do prioritization because the challenges are the problems are many, so we prioritize what they want to do with limited or no resources at all. Then we develop the change ideas and measure them against the indicators. Then we support the facilities and district also on how to maintain it. So as you can see from the lessons that we learned actually, we have seen sustained commitment from national level, that's the Ministry of Health and the DHMT and the facilities as well. Then also we have aligned, the partners have aligned their initiative as against the government QI initiative. And now we have harmonized the training manuals and training guide for quality improvement. Then we have been reporting QI projects from the learning facilities. Then intrinsically you will see all the teams are motivated, though they need more, but at least they are motivated to continue working. Then also we want now to see how best we institutionalize QI improved. It has been improved. Then we see regular meetings among them. We have formed QI governance and we are using WhatsApp groups to report. Even as I sit here, I've been receiving reports from the districts. The strategies actually that we are using to see that QI plans are sustained. We have now integrated on-site support by clinical mentors and the QI coaches. They go together, the mentors and the QI coaches. Then we want the operational capacity of the national and district quality management structures. They are now meeting. Then now we are moving from QOC focal persons to have dedicated. So we are working at the ministry level to see that QI is now a career that people can pursue from that level on to the Ministry of Health. Then now we are working to see how we strengthen the M&A system and the reporting system. And we have integrated QI into the existing governance structures of the Ministry of Health as far as district level. Then we are now collaborating very well with our partners, and we are going to use continuous training and mentoring for us to be able to have a pool of QI resources at that level. So for challenges, basically, one of the key challenges, we don't have dedicated staff for QI work because they have other work that they are doing. And also there is a weak M&A system, then also the issue of funding. So basically, these are some of the challenges we've started seeing. I want to thank you very much. More detail was presented yesterday, and when we go into our groups today, we will learn from each other. Thank you very much.
Thank you, thank you, thank you. Thank you very much. I think she was the only one who was able to do it within the 8 minutes. I will invite the partners to join us now. Pierre Barker from IHI, Lily Kak from USAID, and then Rajesh Mehta from CRO. Please join us here, and then you also have 5 minutes each to speak, and afterwards we're going to take our questions. So Pierre, please join us. You want to go? Okay. Okay, so I think Pierre, you're starting. Right?
Thank you very much. And hi, everybody. I'm Pierre Barker from IHI. There were 3 great presentations that I think gave me, and I'm sure all of you, a lot of encouragement about the work that is really starting to take off now in the QED network. I wasn't here on Monday morning, but I hear that there were some equally wonderful presentations from the countries showing that this work really is now gaining traction and starting to take off. In the Ghana presentation, I think very exciting to see a run chart at the end actually showing a change in maternal mortality over 6 districts. This is the kind of high impact work that I think is going to really change the way the world thinks about the use of QI, and also put the QED network into prominence, let alone our celebration of saving the lives of mothers. In Nigeria, I think what we saw was the use of a mixed method, and I think we're going to come back to this theme that we're not trying to replace what you're doing with QI. QI is being incorporated as a method to accelerate progress and help the systems. And a really very impressive presentation from Sierra Leone showing true integration of QI into their systems at multiple levels, and I think we'll be looking forward to seeing the results of that work coming in the future. I wanted to reflect a little bit on the experiences that we at IHI have had. We've been working in a number of countries, working with governments, working in a large scale, and really kind of trying to reflect on what it's going to take to improve the support of this effort right down at the front line and also at the management levels. Part of the issue is that this is hard work. All of health systems improvement is hard work, getting the supplies there, getting the training, but now we are adding onto that a mind shift. This is a major culture change in the way that implementation is undertaken, and that's hard. And I think that's the journey that we're on, and that the part of the puzzle that is going to be, I think, for us the hardest to do, and I think that the countries are going to need the most support for. So we're moving from really an inputs-based system and a training system and a system that focuses on what's not there in terms of all the facilities and the drugs and the equipment, to one that takes care of that, plus looks at a more modern way of changing systems. So there are some fantastic examples that I think that we should learn from. I think the one from Sierra Leone really demonstrates how from the national level down to the district, down to the front line, you can integrate quality. I think the example that I'm most familiar with, and I don't want to show you that I have favorites, but the country that I know the best, having done this comprehensively, is Ethiopia, where I think that and if Dr. Munir will indulge me to allow me to just describe what I observe, there is the inclusion of a national quality strategy into a major country transformation plan, deep commitment at the country level to the new way of doing things, the culture change, the moving from inspection-based, punishment-based ways of using data to encouraging people to use data for improvement. A deep commitment to building a quality improvement capability unit within the Ethiopian health system, not relying on partners to build sustainable capability for QI, but this continues into the future. And then, of course, a very systematic scale-up plan for the country. Ethiopia is now moving rapidly to scale up improvements in maternal and newborn care, and I think that we'll see phenomenal impact of that in the time to come. So let me just, I know I've probably just got about a minute left, but I want to summarize what I think that the barriers are to implementing quality, both at the front line and at the management level once we're trying to do this type of work. First of all, culture. We're not used to encouraging people to undertake this work. Typically, we are using audit systems, we're using standards checking, we're using an environment where if something goes wrong, somebody has to pay. We're trying to change that culture because we know, and I think we saw that in the Ghana results, the deaths are being suppressed. We don't know how many deaths are really happening for neonates in those Ghana districts because people are frightened of reporting data. So we've got to train leaders in new ways of thinking right up and down the system. Secondly, technical skills. Quality improvement is not something, as Nigel mentioned this morning, it's not something that is taught in medical schools. It's not something that's taught in nursing schools. We have to do a lot of catch-up, and we have to use the examples, the modules for training that we have. Thirdly, I've noticed that quality improvement, if the government is trying to do this, often they don't have the personnel that can go out and do the training, the mentoring visits out of the facilities. They don't have the transport that can get out there to do the mentoring and coaching visits. These are all functions that in the old format used to be done by technical partners. We have to solve these problems. We're going to talk about data for improvement later, but I'll just mention that as a major one. And then finally, all of this rolls up to what we call the QI dose. If we're not providing enough support for QI, if it's not a regular thing that people are doing on a daily basis, looking at their data on a daily basis, it's not going to work. I think I've gone over my time. Okay, thank you.
Thank you, Pierre. Can we put our hands together for him? Yeah. I think you've made very insightful reflections. So I think Lily, yeah, you can also take over now.
Thank you. Hi, I'm Lily Kark from USAID, based in Washington. I want to start by saying that I would like to speak on behalf of my colleagues from various USAID missions who have come from different countries, and I'd like to acknowledge their presence here. If you could just stand up for a second, that would be great, so we can acknowledge your presence, our USAID missions. Thank you. So we have representatives from 4 countries: Ethiopia, Uganda, Tanzania, and Ghana. Uganda, yeah. There were others out of the 10 first wave countries. We have 8 countries where we are providing support to governments to improve their quality of care. And not everyone could attend this meeting. So I'm really speaking on behalf of all of them. So those who are familiar with USAID's program, you are probably aware that quality of care has been a long-standing area of priority for USAID's support to countries. We have been providing that support for many, many years before this network was even conceptualized. So I'm really pleased to say that with the help of this network, I guess the key value of this network is that we have seen greater interest. I think many countries have actually been galvanized to intensify their effort in quality of care. There's more it's really risen as a national priority. So we're very, very happy to align our support, even though we've been doing this for many years. We think that this network has been a wonderful gift for us to be able to align ourselves to national harmonized efforts. So USAID has played a very significant role in supporting the network's activities at the country level. And I just hope that we can continue to provide that kind of support. What I wanted to do was, because our support is so diverse, really contextualized for every country and for every setting, what I wanted to do was talk a little bit about the types of support we are providing on the ground and give you maybe an example of 1 country or 2 countries of where that kind of support is being provided. So at the global level, we have provided quality of care support through our global projects. Many of you have come across them. One is ASSIST, implemented by URC. We have Tamar sitting here. The other one is MCSP, Maternal Child Survival Program, another global project. We have Kathleen Hill. I don't know if she's here, but there she is. excellent people, great partners. We are very fortunate to have them. At the country level, we have almost every country has its own bilateral project, and they all have their names. And I think that particular country would be most familiar with that bilateral project. Some examples are ONSE from Malawi, Boresha Afya from Tanzania, Mamoni from Bangladesh, Transform from Ethiopia, and so on. So through these different mechanisms at the global level and at the country level, we are providing support to governments. And we also provide support to the private sector. And we are very fortunate we have implementing partners that really are experts in this field. In fact, Pierre Barker, from IHI we are very fortunate. IHI is one of our implementing partners in Bangladesh, for example. URC and JAPIGO, MSH, Save the Children, Pathfinder, these are all partners and they're all experts in this field. So in partnership with these implementing partners, we provide support to governments. So what types of support do we provide? So here are some examples that I could think about just in very quick summary. We provide support to governments to develop their national strategies and policies on quality of care, and then we provide support to them to implement them at the subnational level. A very good example of that is Nigeria, where with Kathleen Hill's leadership under the MCSP project, we worked to support the government of Nigeria to help them draft their national strategy on quality of care. And then we're helping them implement it in 2 states, Kogi and Ebonyi states. And you just heard an example from Cross River State in Nigeria. So those are the states that we're providing support, and we anticipate supporting about 5 or 6 states going forward. So that's at the national level, going down implementation at the state level. And then another example is how we provide support to governments by setting up what we call TSUs, or technical support units, at the national and subnational level. And India is an example of how we've done that. So we have units sitting at the Ministry of Health. So they're sitting with the Ministry of Health people, working in partnership with them to provide technical assistance to improve quality of care. So we're doing that in India, as I said, to help roll out their quality of care program called Laksha. And I think we have the India team from here who could also talk more about that. Then we support the quality of care institution. For example, the quality.
Lily, I think your time is up. If
Oh,
you
it
can
is.
wrap up,
Oh,
yes.
my goodness.
You're already
All right.
2 minutes
Sorry?
above your time. So just wrap up and then. Yeah.
Okay. So we have Bangladesh, the Quality Improvement Secretariat. So we support them with that. And another very interesting one is we provide sub-grants to district-level management teams. We're doing that in Ethiopia, providing sub-grants to the Woredas, the districts in Ethiopia. We're providing support to the private sector in Uganda, and so on. And in addition to these more targeted kinds of support, we're also giving support to more sort of broad health systems strengthening, to governments, such as leadership and management, skills building, human resource capacity building, data utilization, commodities, insurance, and so on. So let me stop there.
Yeah, thank you very much, Lily. So can we do it better for her? Okay, thank you. So please go ahead now.
Thank you, Chair. So reflecting on the 3 excellent presentations we have this morning, and then some expert observations, allow me to visit some of the basics. And my summary is for the country colleagues. There are experts in the room. Please forgive me for taking you to the basics. In our business of saving lives, training of health workers has been our most familiar tool. And training has also evolved from didactic training to participatory interactive approaches to electronic trainings. But we soon realized training once is not enough. So therefore, we progressed to provide subsequent trainings, and some good examples which we consider as a prototype is IMNCI. The young crowd here may not be familiar, but IMCI is well known, where they introduced that after the first training, which was already based on adult learning principles and interactive clinical hands-on training rather than lectures, was to be followed by a post-training visit by the trainer or the facilitator in about 12 weeks. Why? Because the trainer would then visit the trained worker in his setting or in her settings to understand whether she is already complying to the clinical practices which were given in that 12 days training. But many countries in my region could not follow this supportive supervision mechanism. The global IMCI review also suggested 2 years back that many countries did not do this. But the proof of principle is there, that supportive supervision could be one answer. Therefore, integrated supportive supervision, we learned from one of the presenters, is going forward. This supportive supervision, pardon me if I, in the interest of simplification, say that if this happened periodically, would be mentoring or coaching. And I don't want to distinguish between mentoring and coaching. Let me take them interchangeably. So now when we progress, the most trainings which happened have been to improve clinical knowledge and skills of health workers. Do you agree? That's the primary the purpose of training is knowledge and skills based on clinical practices. But please make a distinction from that training to an improvement science training, which is different, which begs you, the healthcare teams, to look at their situation and look at the problems, why they are not able to practice what they have been taught. So please make a distinction that clinical skills and clinical mentoring is one stream of work, and QI training and QI mentoring is another stream of work. And as soon as you integrate the two, as we saw in the third presentation from Sierra Leone, probably, where integration is already being mentioned. So what we are doing in our region, this mentoring and coaching on-site visits is one part of the work. And on-site is being offered in my region in two ways. Peer-to-peer, that means the clinical leadership or clinical staff visits another clinical staff, another clinical team, and provides clinical mentoring. That is very common in my region. The other is that we hire some experts who visit the teams for clinical mentoring, and we have seen examples in India, in Indonesia, and in many other countries. QI is a new thing in the region, and we are finding that QI expertise is not great. There are not many experts, so we are pooling resources from partners and offering that QI experts, once they give QI training, must continue to provide on-the-job support, which is QI coaching and mentoring. And while clinical mentoring goes on, QI mentoring also is part of it. And at one stage, we will have one person who would have both kind of expertise, clinical as much as QI, and then that person would be good enough. Now my problem is, there is no money for or logistics for supporting such visits frequently. The governments are not investing money into this. So then I resorted to a little bit of off-site or remote coaching through calls between the QI facilitators and new QI teams, through long-distance calls, through Skype, through WhatsApp, and try to support their work in the initial phases. It hasn't worked much, but it has started to show some possibilities. Then we are creating hub and spoke models. WHO Collaborating Center at AIMS tries to be hub, and then provides support to the spokes in the field, and collaborating center actually does across the countries. So we are looking forward to similar models at country level. So that is how we want to progress for mentoring and coaching support. My other problem is that one, that logistics of visits. Second is there are no line supervisors in many countries. So even if IMCI basic training, there were no supervisors. So India, we tried graduates of home economics, the graduate students from those colleges or schools, to train them in IMCI and say, you please be available as supervisors for the community health workers to finish that, to offer that additional advantage of supportive supervision. So we are suffering because there are not many supervisors who have these kind of skills. So we are depending on training the clinical leaders in this so that they can offer this support while the government sets up the whole structure and the mechanism. So therefore, I think we have seen the beginnings of this journey, the QI coming together with the clinical mentoring, and the third stream, we have seen the quality assurance group within the system, which wants to visit the facility and does a checklist or an infrastructural checklist. So these three streams of work could happen concurrently. That system facility checking happens, which will be less periodic, but then clinical mentoring and QA mentoring must happen more frequently. And then we have this possibility of teams at the cutting edge of healthcare taking the lead and delivering best practices. Thank you so much.
Thank you very much. So can we put our hands together for all the presenters and then also our partners who give reflections? Maybe we'll open up for a few questions. I think we are already run out of time. But if there are any burning questions or some contributions that, can you raise your hand, then I can spot you, maybe 2 or 3. So the first one is Cameroon, and then Nigeria, and Ethiopia, and Liberia. Yes, please. Yes, so, yes, go ahead.
Okay. Thank you very much for the 3 presentations. And I'm very happy of the last intervention about supervision, because I had a question on it, but it's clarified now. I have a question for Ghana and Nigeria. For Ghana, I really like to know about sustainability plan. Nigeria talk about it, but I have not heard about sustainability plan and human resources plan. Because we have a problem in our country, is that we are training people and they are not staying in the workplace. How to do to maintain them? For Nigeria, we know that Cameroon, we have some similitude. And one of the similitude is the security environment. And I wanted to know, in the district that has been chosen, is there a district with a problem of security? If not, when you will scale up, do you program to make this district in as a special district? Because we know that the problem of security is very important in our country, and there is some districts that have very lack indicators, mother-to-child indicators, because of this. And it's very important to have special strategy on this. And I wanted to know if you have planned to have a special strategy for this district about these issues. Thank you very much.
Thank you. So Nigeria?
My name is Joy, country office, WHO Nigeria. My question goes to Sierra Leone. First of all, I want to appreciate my colleagues for the wonderful presentations. Sierra Leone, you talked about your lesson learned, that the health workers were motivated. Please, can you throw more light on that? What kind of motivation was that? And how sustainable is that motivation, so we can also learn? Thank you so much.
Okay, thank you. Liberia, yeah.
Okay, thank you very much to the presenters. And as we are the newbies, we call us, we are very keen on learning the lesson, especially the best practices. So I just wanted to ask my sister country, Sierra Leone. The initiative was very good, especially at the 3 level, the the clinical mentoring, the QR coaches, and also the mentors at the various levels. But what I want to know is, how was this done? Is it across the entire country, or was it in some region, all facilities? How did it happen? Because whether there was some way of criteria for inclusion, if it did not happen in the entire country and in all health facilities, just to learn how it happened, because this is a very good initiative. Thank you.
Thank you. So I think we will try to answer the first batch of questions, and then we will see if they will allow us another round of questions, and then we'll do that. So just hold on. We will answer this one. So maybe we'll start from Ghana.
Yeah, thank you for that question. Yeah, Ghana, we have learned some lessons from the previous experiences that we have implementing quality improvement initiatives. What we did, particularly in Volta region, we have had training for QI teams, and after 2 or 3 years, they fade off, and then we have to go back and do the training again. So in doing this project, we realized that to sustain the gains that we make, we need to bring leadership on board. In fact, we look at 3 main domains: establishing a culture of continuous development, quality development in these 6 districts, looking at leadership development and team building, and then looking at partnership engagement and development. So when we started, we included management. We started with management, and we didn't do the work from outside, but we just facilitated the work that has been done by the teams. So at the end of the project, leaders of the various facilities already recognize the approach that we have used. So we could say confidently that moving out of these 6 districts and scaling up to other districts, the leaders have had opportunity to share the benefits that they've had with other leaders in the region. And as a region, we have also seen that the impact that it has made. So as a region, we have decided that as part of our annual budget, every district in the region should allocate some resources for this kind of work. Human resource movement attrition has been something that we have also experienced, particularly in one part of the region which is very deprived and far from the center. So what we have done was to locate a midwifery and nursing training college in that area to take care of the attrition that we see periodically, and also motivate them by establishing a system of continuous self-improvement, because people will always want to go to school. So we have linked up with the university in the region to establish a modular courses for the nurses, so that you will not necessarily have to leave your workplace to go and stay at on a university campus to upgrade yourself. So that has controlled the fast movement of staff that we have seen previously. Thank you.
Nigeria?
Yeah, thank you, Cameron, for that question. I appreciate your concerns. I believe it's born out of the recent challenges you have in your country, particularly the side bordering Nigeria. And you'll also, if you have been adequately informed, you'll understand the government of Nigeria is doing a lot in terms of physical security to ensure that what is happening in Cameroon, Nigeria is helping in its own way, because there was a time some of those people who were involved in this crisis were arrested and sent back. That is to show you that Nigeria is up to date in terms of ensuring that there's security in that angle. Secondly, we are effectively employing measures to adequately get the community to participate in what we are doing, particularly in the health sector, and also the interest of these pregnant women. There are a lot of helplessness that have been pushed into that area. We have some camps. Some of them are even integrated into some families. Into some families in Nigeria. By doing that, I think is a way of, improving on the security of the area, particularly those Cameroonians who come into Nigeria. And of course, you cannot do all this without appropriate or adequate funding. The Cross River State government is done a lot by improving on the revenue, the budgetary allocation for the Ministry of Health, which has increased by about 10%. No, not up to 10% of what we were having before. So I think that is one way of trying to ensure that there is improved security in that area. Thank you.
Thank you. Can you respond to the question?
Thank you very much. Thank you very much for the questions. For the motivation you were asking, I actually mentioned it's intrinsic. It means when during our trainings, we normally try to really talk to the health workers to see the need for quality, because it has to be a behavioral change and changing of mindset. So we have tried PBF after the war. We tried the performance-based financing, and we saw when the PBF ends, sustainability was an issue. And also we have seen post-Ebola IPC. So for QI, what we are now trying to see, we want them to really see the need for them to change. Then secondly, Sierra Leone has a lot of trained volunteer workers. And the last regime, they did not recruit them into the government. Actually, the Ministry of Health is the key employer of health workers in Sierra Leone. So what happened was, most of those volunteers, the government actually initiated a quick process for them to be recruited by the Ministry of Health. And that also added on to the motivation. Then secondly, when the different units see the performance of one unit, when they start the QI projects, the others became like the military hospital at Western area, Freetown. So basically what happened, we started with the maternity ward. That was the ward when we did the baseline, we had like less than 10%. They did not score. It was less than 10%. So once we initiated the QI project in partnership with our partners, ICA, we saw they have even gone beyond 100%. So now the adjutant or the head of that hospital actually requested that we expand to the other units. So based on what they have seen that the maternity has done, the other units became interested. And once you have interested health worker, they are willing to move and see performance. So that's basically the intrinsic motivation I was talking about. For the selection, yes. What we did actually, we used the MDSR report. We have had MDSR report for 3 years. So we looked at the key indicators, the districts that had the worst indicators. Those were the districts we prioritized. Then also in the regions, then in selecting, we developed a national criteria, because we have to guide our district or subnational levels for them to be able to select appropriately. So we did a criteria. One was the ones that has more events. If you have more deliveries, we know that can be a learning site where people will go and learn. We don't want to go to a facility where you will maybe per month you will not be able to see more deliveries. So we did that criteria national level, and we encourage our district health management teams and facilities for them to add on. It was just a guide. And we went to facilities where we have partners, because partnership is key. So what we did is, where we have existing partners, we know some of the QI interventions may need resources, and we will not be able, like our technical experts we are mentioning about supportive supervision, and also the improvement packages. Some may require resources. So whereas we have a partner, we encourage them to choose a facility as a learning site where there is a partner, where they have more events, and also where they will be able to, we discussed again with the Ministry of Health, especially the Directorate of Nursing and Midwifery, because what we have seen is staff attrition. You will train one person, by the time you go, that person has been moved, or they go for training. So what we did was, once we have trained a team in a particular setting, we encourage them to stay there at least for 2 years before they could be moved. And before they move, so basically when we go into our groups, try and locate Sierra Leone, they will be able to exchange ideas. Or our posters are outside. You can still look at it if you need more details. So I want to thank you very much.
Thank you. Can you put your hands together for the analyst? I'm supposed to do a quick recap of what has happened. We ran out of time, but I think basically we all can see clearly that it's important that we do our clinical skills. In terms of the knowledge, that is more theoretical. We need to practicalize all these things in terms of our coaching, in terms of our mentoring, and then also supportive supervision. I think we wouldn't be able to have enough time to pick the other questions, but remember we're going to have our group sessions. We would encourage participants to locate the various groups and then be able to ask a few more questions. And then I think we will be in positions to support each other. This is a networking opportunity. Even during the snack break, we should be able to do that. On that note, I'd like to thank all of you for the support. Thank you. So we're going to continue with the second session, which is supposed to be the data. Yeah. And for Ghana, my colleague, Dr. Anthony Ofosu, will take up and co-chair. I don't know whether the Ugandan colleague is also around to co-chair with my colleague who is coming now. Thank you.
Hello, my name is Anthony Ofosu, and I'll be co-chairing with Uganda, but they are not around, so I think I'll continue. You'll be coming? Okay, so come over. Yes. Let's give my colleague co-chair a round of applause as he comes up to support me, chair. But before we start, I think Nigel will have something to say to introduce the session.
Can you go to slide 5? Slide 5. Up. Back. Go back. 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 Great. So yeah, those are great presentations and great reflections from the panel and great precise questions from the audience. This is challenging. This quality improvement is often a new idea. Building the capacity in country, in government, and then mechanisms to get this to the front line isn't going to happen overnight, but it's great to hear progress on how this is happening. It's also good to hear the practical challenges. One of the practical challenges that Pierre mentioned is the issues around data. Quality improvement is much easier when you have good data and when you're able to talk openly about the data. And our health systems don't always have the data that we need, and we often have a culture that encourages hiding. It's hard to have a 50% reduction in neonatal and maternal mortality when you're at 0 because you can't report deaths because you're in trouble. So we have to talk about how we fix the measurement. Next slide, please. Right? Oh, sorry. Next slide, please. Yeah, it's broken. It's 2 slides. Go to the next one. So today we're going to hear from different countries and then break into the different groups, and the objectives are to discuss the challenges and lessons at the national, district, and facility level around having data available. Data for understanding what's happening with patient care, and also data for understanding whether the things that we are saying we are implementing, whether they're actually happening or not. And then we also want to talk about use of data. What have we learned about building the skills on using the data and changing the culture so that we are encouraging people to bring out the problems? And then we'll talk about how this is being transferred into sustaining these efforts in the government systems. So, thank you.
Thank you very much. Thank you very much. So this session is about data, and it will explore the characteristics of data systems to support effort to improve quality of care for MCH in countries and identify opportunities for integrating this into the broader health data improvements investments of countries. So basically, looking at how we're going to use data to drive quality of care improvement. And we'll be having country presentations by Cote d'Ivoire, Bangladesh, and then United Republic of Tanzania. And then we'll have partners' reflections also. With me co-chairing is Dr. Okwari Joseph. So we will welcome our country presenters as they mount the podium to give us their presentation. So we invite Cote d'Ivoire, Bangladesh, and then United Republic of Tanzania to come up. Let's give them a round of applause. So our panelists, the rule of engagement is that you have 8 minutes to present, and then we will take partners' reflection. They also have 5 minutes each, and then we'll take questions from the audience. And then my colleague, Dr. Okwari, will round up the session. So first, we'll take the presentation from Cote d'Ivoire. So Cote d'Ivoire, you have the floor.
Bonjour tout le monde. Je suis Dr Saki de l'OMS. L'équipe de la Côte d'Ivoire m'a chargé de vous partager sa petite expérience dans la qualité des soins. Diabo. En attendant que la technologie marche, juste pour rappeler que les indicateurs de santé de la Côte d'Ivoire ne... Non, avant. C'est parti trop vite. Diapo. Voilà. Les indicateurs de la Côte d'Ivoire ne sont pas très réduisants. Je vais insister juste sur le ratio de mortalité maternelle qui est toujours au-dessus de 500 pour 100 000 naissances vivantes. Et les autres indicateurs, comme vous le voyez, ne nous permettent pas d'être dans les pays les plus émergents en matière de santé de la mère et de l'enfant. Diapo. Il faut noter que dans le contexte, nous sommes au stade de la surveillance des décès maternels et la riposte. Et le rapport 2016 nous a montré que 88% des décès maternels, diapo. Next. 88% des décès maternels déclarés ont lieu dans un établissement de santé. Et la plupart des décès étaient évitables. Il faut noter aussi que 5% de ces décès surviennent au cours des évacuations sanitaires. Et les principales causes de ces décès de mères portent sur l'hémorragie du postpartum. Diapo. Quelques actions ont été menées. Diapo. Il y a la création d'un cadre de concertation de toutes les parties prenantes. Et au niveau décentralisé, il y a des comités de surveillance des décès, de revue des décès maternels dans tous les districts. Au niveau national, le pays a identifié un point focal chargé du suivi et évaluation de l'amélioration de la qualité des soins qui est situé au niveau de la direction de l'information sanitaire. Et les chargés de surveillance épidémiologique de la plupart des districts sanitaires du pays ont été formés à la surveillance des décès maternels. Diapo. Au niveau opérationnel, nous avons évalué la qualité des soins dans 15 hôpitaux de référence de 4 régions sanitaires, en plus de l'évaluation qui avait été faite au niveau national en 2014. Et cette évaluation a permis d'élaborer des plans d'amélioration de juin à novembre 2018. Aussi, dans la zone d'Abidjan, où la première évaluation avait été faite, une étude sur l'analyse de l'état actuel des soins néonatale, surtout dans les établissements ciblés de la région sanitaire d'Abidjan, a été faite. Il y a un poster qui a été fait à cet effet. Nous pouvons partager les informations. Diapo. Un exemple de résultat de l'évaluation de la qualité des soins dans un établissement de référence dans une zone de la région du nord-est de la Côte d'Ivoire. Mais en général, on montre que dans tous nos hôpitaux, les scores sont autour de 3 au maximum, par rapport à un score de 5 qui note la qualité. Donc, nous avons besoin de beaucoup d'améliorations, tant au niveau des structures même de l'hôpital que des soins maternels, pédiatriques et néonataux. Diapo. Quelques résultats. Donc, à la suite de l'évaluation de la qualité, les acteurs des structures ont été formés à l'utilisation de l'outil parce que, à la suite de l'évaluation, périodiquement, les structures doivent s'auto-évaluer pour voir l'état d'avancement des données de leur structure et des plans d'amélioration sont élaborés et mis en œuvre pour corriger les insuffisances constatées. Et pour la mise en œuvre de ces plans d'amélioration, les sociétés savantes accompagnent les équipes des districts pour régler les différents problèmes qui sont relevés. Diapo. Par rapport aux données, les outils de collecte, on avait constaté que beaucoup d'outils de collecte n'étaient pas bien gérés dans les structures sanitaires. Donc maintenant, les outils de collecte des données sont renforcés et disponibles, entre autres les dossiers médicaux, les registres des décès maternels et pédiatriques, les fiches de notification des décès et le suivi des indicateurs de la qualité des soins. Et les comités de revue des décès maternels sont redynamisés afin de leur permettre d'organiser les revues régulières dans les structures. Diapo. Cependant, nous avons quelques défis. Il faut noter qu'au cours de l'année 2018, au dernier trimestre, nous avons reçu des outils pour la collecte des données par l'équipe de la qualité du réseau mondial qui est venu nous assister un peu. Ces outils étaient en anglais. Nous avons pris le temps de les traduire tant bien que mal en français, donc ça prend un peu de temps. Et il faut dire comme défi l'intégration de certains indicateurs de qualité dans notre système national d'information sanitaire. Dans les mois qui suivent, la direction de l'information sanitaire est en train de réunir tous les programmes en charge de la santé de la mère et de l'enfant et les autres programmes pour intégrer les données spécifiques dans le logiciel qu'on appelle DHIS2. Et le deuxième défi, c'est que les données soient analysées de manière régulière et que la diffusion de ces données soit assurée à toutes les parties prenantes pour une meilleure prise de décision. Diapo. En conclusion, il faut dire que l'évaluation de la qualité des soins et l'intégration même de la qualité dans toutes nos interventions a permis de mettre en évidence des dysfonctionnements, de mettre en œuvre et de suivre les plans d'amélioration. La mise en œuvre de ces recommandations nécessite la participation de tous, tant au niveau de la structure, des prestataires, la communauté, mais surtout des sociétés savantes qui sont très, très, très importantes pour l'amélioration des diagnostics, parce que la plupart de nos diagnostics sont discordants. Et nous avons des résultats à partir de ce que nous avons mené, quelques résultats probants, mais nous avons des images que nous allons partager avec vous. Je vous remercie.
Thank you very much, Côte d'Ivoire, for your presentation. So we'll call upon Bangladesh to give us their presentation. Bangladesh.
Honorable Chair, Co-Chair, Honorable Participant, ladies and gentlemen, good morning, everybody. On behalf of country team, I would like to present data system for quality of care, which is mainly focused to maternal and neonatal health, and especially monitoring and evaluation framework for Bangladesh. We know data, not only data, quality data is much more effective, much more important for effective monitoring and evaluation system. If you don't have quality data, it is not possible to control the whole situation. So what we are doing on behalf of our Quality Improvement Secretariat, that we have developed a very good quality monitoring evaluation framework. And for this monitoring evaluation framework, we are trying to utilize the quality data. And at the same time, we are trying to address the monitoring logic model of the QED network that is focused to provision of care, experience of care, access of care, and management and organization. So we're trying to cover all of the component of the monitoring logic model. And actually what we are using the data, and data basically are coming from the different routing data source, MPDSR data source, logistic management information data source, and different source, even on client satisfaction as on some type of observation. And we are using this data for development evidence-based planning for effective management of our M&A system in our country. So actually we love to say our country is a digital Bangladesh because we have started our journey from basically 2009. You see, if you see the slide, that actually we have developed the whole digitalization from primary level. I mean the community clinic, sub-center, district hospital, medical college hospital that is held, situated in the tertiary level, and some super specialized hospital. All are covered under the ICT infrastructure. And about 800 hospitals are already functioning in the system, and 19,000 daycare facilities, and around 100,000 health workforce are using the ICT data in our country monitoring framework. So we have a very good and smart dashboard. This is the screenshot of the dashboard that we are using right now in our DHS2. In this dashboard, there are 10 modules. And by utilizing this 10 module, we are monitoring the whole health service delivery focused to maternal and neonatal health services. And that is the prime dashboard of our DHS2 module. That is the RMSH scorecard. You know that we have already developed a RMSH standard and RMSH guideline, and already we have started a piloting the RMSH standard in a selected facility that we have yesterday we have shown in our poster session. So we are using this data for measuring the performance of the RMSH activity in the selected district hospital. You can see that this is in the first column there are the name of the division, and the right of column there are different indicators like the number of registered pregnant women, NC counseling, NC coverage, PNC coverage, full vaccination. And we are measuring the progress. Like if you see that the red area, actually those facilities are not in track. And the yellow area indicate that we are still in progress, but not in track. And the green area are indicating that we are in track. So we are using this dashboard to measure the performance of our implementing activities in the selected healthcare facilities. So I think this data is this dashboard is working is a very effective way in our country to measure the RMSS performance, and whole our data is coming from the routing data system. This dashboard actually monitoring from national level to sub-district level. If you see that the national level, there is the LD dashboard, and then divisional dashboard, then district dashboard, and lastly the sub-district or Upazila dashboard. And in this dashboard are monitoring by the divisional, from divisional director and to the health manager of the different facilities of the healthcare organization. We have a very good SMS complaint and suggestion system, and around 850 facility having a signboard on how to send complaint and suggestion directly to the Ministry of Health and Family Welfare. And the SMS inquiry is done by a designated person of the Ministry of Health and Family Welfare, and they are taking the immediate action after receiving the SMS from the patient, from the client, regarding some issue, regarding some challenges. And at the same time, the health manager promised to solve the issue instant after getting the SMS. And these are the different complaint time that we are receiving from different sources by SMS and phone calls. And according to the priorities of the complaint, we are taking measure instantly to solve the issue in the health facility. And this is the dynamic GIS platform. We have very developed dynamic GIS platform that we can easily plot at the health data, and same time the maps are available from the national level to sub-district level, and also it is available in the all healthcare facility. We can easily identify by using this GIS platform the location of the health facility, at the same time the logistics status, at the same time the manpower status, at the same time the service status. We can easily identify by using this GIS platform. This is another important intervention that we have initiated, that is the default tracking for pregnant mother and under 5 children. That we are tracking all of the pregnant mother by using these apps. Our health worker is collecting data from the field site. They are sending the data from the community level to DHS2, and in the central dashboard we are we are monitoring the situation. Actually, what is the number of total pregnancy, what are the number of total ANC services, and at the same time, what measure we have to take from the central level. And you know that we have already introduced another intervention, that is MPDSR. So we would like to measure the performance of MPDSR by using the incoming data. So definitely we are now we are able to measure the number of days at the home, number of days at the private facility, number of days or percentage of days at the medical college or tertiary hospital. So we can easily see the situation, whole scenario by using this dashboard. And what to measure, actually what are the major concern in the private facility, why mother dies even after taking intervention in the medical college area, and what are the percentage of pregnant mother dying at the home, and how we can strengthen. So by utilizing this evidence, we can easily develop planning that are already taken on board. And at the same time, we're identifying the cause of maternal death by different location by using the dashboard. What are the percentage of postpartum hemorrhage? What are the percentage of eclampsia? What are the other percentage of cause of death in the different locations? So we can easily identify the situation by using the dashboard in our DHS2. This is easily by seeing this data, we can easily see the percentage, what percentage is going on, what are the percentage of sepsis, what are the other clinical condition are responsible. And another dashboard, what are the percentage of ANC services are receiving among the whole population, and we can easily take the measure seeing the dashboard instantly. And also we can seeing the age group of maternal death due to PPH is proportional with the increase of age. So in this pie chart, it is clearly visible that how we can take the measure to seeing the dashboard. And who was delivering when the mother died? This is another important intervention. So we can easily see the situation, actually what measure we have to take further after effective implementation. And thank you everybody. Due to limited of time, I have to shorten my presentation. Thank you.
Thank you very much for your kind consideration. So we'll take the next presentation by United Republic of Tanzania. So Tanzania, you have the floor.
Good morning. My name is Dr. Phineas. I work for the Ministry of Health, Tanzania. And I will be presenting on the data system for the quality of care. Demographics from Tanzania, as presented yesterday on the poster, the maternal mortality is ranging at 556 per 100,000. This is a rise from 432 from the year 2010. And generally speaking, we are doing well on the reduction of under 5 mortality rate, but we have a challenge on the newborn death. The policy environment in Tanzania is supporting the RMNHS services, and this is implemented by the Health Sector Strategic Plan 4, and it's being complemented by the National Roadmap to accelerate the reduction of maternal mortality and newborn. This is the 1.2, which was launched in the year 2016, and it's being accommodated by the RMNHS scorecard. At the national level, we have the Health Quality Directorate with the very functional health management system information. And we have the National Data Warehouse, which we call it DHS2. We use the data at the different levels from the community, from the district, the region, and the national level. At the district level, they use for preparing the CCHP comprehensive health plan, and at the national level, we use it for making the health stories and strategies, and at the international level, it's for aggregation of the data and looking at the milestones. On the data use and the management, we have the system for rating the facilities. We call it the star rating, where facilities are being scored from different domains, ranging from facility management, infection prevention control, account satisfaction, and how they handle the emergency services. So the facility which scores 0, it means not qualifying for delivering the health services. And after rating, it's the entry point for results-based financing. I mean the facilities being financed according to the performance. And the data which are being used are from the National Data Warehouse, the DHS2. They are used as a baseline for tracking the progress. This is the RM1H scorecard. It has different colors. It's the snapshot, so that you cannot see it clear, but it has the output indicators and the progress indicators. The output indicators being the maternal mortality and the contraceptive prevalence rate, and we have the progress indicators, which are the there are some which are being tracked as the quality of care for the maternal, newborn, and child health. We cannot see well, but there are some indicators like antenatal care attendance below the 12 weeks and breastfeeding within 1 hour. So this is a tool which is being used for the tracking the quality of care, but also an accountability tool. Even the politician or any reader like the regional commissioner or district commissioner who cannot interpret the maternal or mortality data can just look at the color and follow up with the officers who are implementing the health issues. So the result-based financing, I've said, it provides the direct funding to facilities, and it has the quantity and the quality indicators. The quality indicators are mainly for the hospitals, and the quantity are the indicators for health centers and the dispensaries. And the quantity earning is identified by the quality of score. So they focus on the immediate needs, which will change over the time as the need change, and the payment is being done after the internal and the external verification. So we have done some initiatives to improve the quality of care. We have developed the quality improvement plan, which is an electronic tool. So at the health level, when the healthcare provider will make the work plan, an officer at the national level will be able to view this work plan and follow up as appropriate. We have also developed the star rating manual, which includes the maternal and child health quality of care indicators, and we have revised the national infection prevention control guidelines, and we have the complaint management guidelines. Another thing, we have developed the quality improvement framework, which will also help us in improving the quality of care at all facilities. So the challenges, like from other countries, in Tanzania, the facility delivery performance is increasing, and the health, the number of women who are delivered by skilled-based attendant is increasing, but also the maternal mortality is still challenging. The number is increasing, which means the quality of care is not good. And this is from the fact that the quality of care is not good at our facilities, and the other challenges are from the data, like data completeness, consistency, and the infrastructure, whereby we have the roads which are not passable, especially during the rainy season. Other challenge are some facilities they cannot manage to use data for quality planning and priority setting. You may find the facility having the challenge in the like breastfeeding within 1 hour as an indicator which is not performing well, but they prioritize in the medical supplies and equipment, so they cannot use the proper data for planning. And there's low integration of quality follow-up and the supportive supervision. And we have many tools which are collecting data, but some of them they are not being used. So there's a high burden for data collection. And some facilities are setting the targets which are very high, which cannot be reached in time. So what we think as the way forward is to adapt the WHO quality of care framework for maternal, newborn, and child health, and we develop the dashboard for this framework so that it can be integrated in the National Data Warehouse, the DHIS2, and we develop the quality improvement training manual for training the quality of care at all different levels. And we are currently developing the clinical audit guidelines so that we manage the quality of care at all facilities. Thank you very much.
Thank you very much, Tanzania. So now we invite the partners for their reflection, Dr. Kathleen Hill, MCSP Japaigo, and Dr. Wilzek, UNICEF. So would they kindly come up and give us their reflection? Let's give them a round of applause as they come up. So they have 5 minutes each of reflection. Well, I've been corrected. It's 5 minutes in total. So you have 2.5 minutes. Okay. Sorry about that. Okay, so we first take Dr. Kathleen Hill.
Thank you, Mr. Chair. Good morning, everyone. Thank you very much to our panelists. It's my pleasure to offer some reflections, and I really have enjoyed being here this morning and hearing the extremely encouraging work from both panels. And I'd like to just offer a few reflections based on what we've been hearing. One thing I'd like to just start by is that, as you've all seen in your packets, we do have a monitoring framework for the network that very intentionally outlines the kinds of data that are needed by different actors across the system. And I think we saw I'm sorry, I'm a little short of breath from the altitude. I think we saw a wonderful example from Tanzania of really outlining the different data needs. I think we've heard some really common themes that have come through today. One is that the use of data to design and to plan improvement work, as well as to monitor whether or not the changes and the activities that we're implementing are actually improving care. And I was really excited to see some of the wonderful examples of using data to actually plan at the subnational level. So I think we saw an example from Ghana, from Cote d'Ivoire, of stepping back, and also from Bangladesh, of stepping back, looking at the subnational level, where is the mortality occurring, which districts, from what causes. We saw from Bangladesh some amazing examples of using data around leading causes of death in different facilities, et cetera. And I thought that was really a wonderful example for all of us, because we talk a lot about the monitoring, but I think the planning and the use of information to plan improvement is really essential. We also saw that there's a mix of data that countries are often using around planning and prioritizing, including routine information systems and PDSR. We saw from our colleague from Cote d'Ivoire the use of assessment in some major hospitals. We also heard a number of our countries talk about the challenges with the lack of availability of basic data elements within routine information systems. And I think we can't overstate this enough based on what we're hearing from our countries here and what we also know working in many countries. The program I work on, which is a global program, did an analysis of the availability of M&H data elements in routine information systems across 24 countries. And only one half of those countries actually had cause of death aggregated within their routine information system, and the number was even lower for newborn cause of death. So I think the question of having basic data elements in our routine systems to allow us to be able to know why women, newborns, children are dying and to use that data, but we're still a far away from that. I think the same issues come up with the availability of data within basic frontline registers and patient records. I think we heard from one of our countries that, often from Côte d'Ivoire, that often in the frontline dossier, that, the basic data is not available, both in terms of process measures as well as outcome measures. And I think this is something we all struggle with, and really a challenge and an opportunity for the network. We also heard about data quality, and that came up several times. And I know that many of the countries are very, are working hard to address the issues of data quality. We know this isn't easy, but I think there's some wonderful examples of actually applying quality improvement principles to improve quality of data, monitor quality of data. We heard a very nice example in a previous meeting of some of the efforts going on in Ethiopia to examine data quality and improve it. We also heard a great example that when we begin to, I think we heard this from Ghana, when you begin to actually monitor more systematically, for example, newborn mortality, you can expect to see it increase before it comes down. And I think that's something as a network, if we can be open and honest, that as we begin to better understand and track these outcome measures, we will see sometimes things get worse before they get better. So I need to stop. So the last thing I'm just going to say is around the integration of QI and clinical capacity building that we've been hearing a lot about. And I see measurement as just integral to QI skills. And I think we've heard some really nice examples that as we're supporting facilities, as we're working in districts to really integrate the QI, the measurement, the clinical, we know that the measurement capabilities around calculating and using and prioritizing quality of care measures is actually, in some cases, needs an enormous amount of support. And I encourage you to look at the catalog of indicators in the monitoring framework that gives some suggestions. I'd like to just end with, we had a couple of really interesting examples, including from Bangladesh, about trying to monitor experience of care. And I think this is one of the strengths of this network and the quality of care framework that WHO has developed, and we thank you for that. And I think that we're all learning around the world everywhere about how we actually begin to regularly listen to our patients' voices and do it in a systematic way as part of ongoing improvement. And that's something that no one has the answer to, and I really look forward to learning from all of us as we go forward. Thank you.
Thank you very much. So we'll take Dr. Wozek's comments.
Yeah, thank you. I think the three presentations really show the wealth and how much we progress and how many efforts are being made. That's really great to see. It's not only about the data generation, it's data use, and I think this was really shown very well from all the levels, from hospital down up to a national level. Also the scorecards. Sometimes the blame and shame, mechanism works well. Also incentives, as we saw in Tanzania, the results-based incentives. So we have tools to improve quality and to make sure that quality is really being implemented. And in terms of data use, even at a hospital level, very often a woman comes in her third or fourth pregnancy, and then the main issue in the outpatient department is to find the previous files. The file is not there. The mother might be unconscious, she has preeclampsia, or she's fitting, and you have no idea what happened in the previous pregnancies. And many of the answers might be in that file that you're looking for. So we have more and more tools, and I think the technology is helping us. We heard GIS, but then also, especially in conflict and also humanitarian settings, it's very helpful to have digital data sources. Also in disaster happenings like typhoons and other natural disasters, files can get lost very easily, and if we have them digitally, it's much easier. What I want to draw attention to is to look at both spectrums of quality of care. We discuss here a lot the low capacity setting, but we also see, and for those, I'm sure you're aware, last year the Lancet series on cesarean section came out, and it's just amazing
what we are expecting, what we are seeing in terms of the massive numbers of cesarean sections that are being done globally without reason. And that's happening across the board. That's happening as we hear in East African, but also West African setting, in Asian settings, because it's such much easier sometimes. And I would believe you also have to work on the quality of, in that sense, in terms of the cesarean section. What I found very interesting, for instance, from the Lancet series, the most common time and day of a cesarean section globally is Friday afternoon. And I'm an obstetrician gynecologist. I understand that you want to make your case on Friday so you have a nice weekend, but this is not the reason for a cesarean section. I'm just saying, and especially the private sector is not disclosing this data, but we need that data. So we have to make sure that the public and the private can work together, and we can see what is also happening in the private sector, because many of the cesarean sections, like in Brazil, for instance, 80% of all deliveries in the private sector are cesarean sections. I'm just saying, let us not forget the other spectrum, which is becoming more and more important in low, middle, and also high-income countries. And then, yes, finally, on the district, I think the use of data for mayors, and especially in decentralized settings, is very important. And I think such a dashboard that you presented from Bangladesh is very helpful, where a district officer, but also a mayor or provincial, can immediately see where the gaps are and where you have to invest when you look at your health system at district level. And yes, maybe the final point is, I think what was said before, a culture of openness. Especially on a hospital level, people don't want to talk about deaths, especially when it's about maternal deaths. In some settings, there's some legal implications. In some other settings, it's not a legal implication. It's just a family, who will, of course, react to the death in her family and come up to the doctor, and there might be even threatenings and so on. So many doctors don't want to talk about it, but we need that open culture. And the open culture has to be between obstetricians and neonatologists, because we have to see it as a continuum. And if a mother dies or a newborn dies, we have to see both cases. So I think that collaboration of professionals on a hospital level is very important. So that's all from my side. Thanks.
Thank you very much. So we thank all the presenters and then also the reflection from our partners. So we'll take the questions and answers. So section. So I'll hand over to my colleague, Dr. Okwari Joseph, to do that. Thank you.
Okay, so thank you very much. I didn't hear you appreciating the countries and the reflections. Yeah, thank you very much. They have been kind enough to share with us. I know that data is very important, and we need to build systems to be able to measure, because what gets measured gets done. What is not measured is definitely not done. You can't report anything about it. And yesterday, there was one slide that said that measure what is important, don't just measure what is easy to be measured. And these three countries have definitely demonstrated use of a lot of technology and innovations to be able to capture, the data that we need to track our improvements. Time is a critical issue. We have 15 minutes only to do the questions and then answers. Less than 15 minutes, my co-chair. Okay. 5 minutes for the questions, and then the 2 minutes for quick responses. And we have 3 blocks in the audience, so probably 2 minutes here, two. Those are 6. So by show of hands. But don't worry, I am aware that there are smaller groups that are going to occur after here, so we will still have time to engage later after this session. So I see a hand. We start with this block. There's only one. The country is not showing. Okay, then DRC, number 2, Sierra Leone, number 3, Ghana, 4, and 5. We start this end.
Thank you.
One less than a minute each.
Okay. Thank you. I have a question for Bangladesh. They say they collect data from the community level. So I need to know who is collecting those data in the community. Is HAW or outreach nurses?
Okay, thank you. Number 2. was DRC. Thank you.
Merci. Ma question s'adresse aussi au Bangladesh. Dans les tableaux de bord qu'il nous a présentés, il a dit qu'ils savent combien de décès ils ont eu, combien ont été revus. Maintenant, j'aimerais savoir un peu dans quel outil ils mettent les recommandations issues de ces revues. Parce qu'il a parlé de DHIS2, qui est un outil de données de routine. Maintenant, les recommandations issues de ces revues, ils les captent dans quel outil? Est-ce qu'ils ne font rien, ils attendent seulement à la fin pour voir s'il y a moins de décès ou plus de décès, ou s'ils ont un outil qui leur permet de capter les progrès successivement dans les recommandations prises? Merci.
Yeah, thank you very much. Then there were two hands here.
Yeah, thank you very much. I think mine is not a question, so it wouldn't need an answer. It's just a contribution.
Okay.
Yeah. So I just noticed from all the presentations and then from our own experience in Ghana that I think that the culture of blame-free reporting is quite critical. And then also in terms of that, then the transparent reporting will help, with specific interventions, because if you don't have problems, then there's nothing to solve. Ranking of like facilities, you look at the dashboard and then also sometimes the scorecards, and you notice that that can also be an opportunity for ranking like facilities, at the same time also generating a healthy competition, but not necessarily for punishment. So that also encourages, staff to report naturally. And the last one that I want to talk about is the involvement of the private sector. I think that is very, very critical, and it cuts across. The data that the private sector generates, usually in many countries, you can't really know exactly what they are contributing, and then also the impact that they are also having in the country. So it's something that I just want to encourage all of us to look at even when we are back in our countries. Thank you.
Good comment. Thank you very much. There were two hands here.
Thank you, Chair.
Your issue was covered?
No.
Okay, continue.
Thank you, Chair. My question is to Bangladesh. Your very extensive ICT infrastructure, it seems to me that it has solved three problems that we face certainly in Sierra Leone. It seems that the higher level hospitals, including the super specialized, are reporting through the DHIS, which ours are not. It seems that your integrated disease surveillance system that also includes maternal deaths is already linked to DHIS2. And thirdly, it seems that you already have patient-linked data. You're able to track pregnant women who are lost to ANC visits. But during the poster presentation yesterday, we actually heard, and I think I'm correct, that you don't yet have measurement around the experience of care. I know Kathleen said that this is happening, but during the poster presentation, that's not what we had. So please correct me if I'm wrong. And if you're measuring the experience of care, what it is that you're measuring.
Okay, then this side, there was a hand.
Thank you, Chair.
Yes, sir.
Yes. So, great presentation from all countries that are presented. I only have one question that is, well, there might be a part question that is related to that as well. The first question to all the presenters is, we've observed in some parts of Malawi anyway, that you have various institutions, some of them private, others public, that will be collecting data from the same centers, and they're funded by different organizations and partners. But the data that they might be collecting would actually be similar. But more importantly, the people involved in the data collection might actually be the same people, but they're just doing it for different projects and different initiatives. My question is the same observed also in the other countries? And if that is the case, how do they ensure that the quality of the data being collected for the different initiatives and partners are actually are not compromised? And secondly, do they ever have problems such as if the same people collecting data for the different initiatives but are not paid by one of the partners will end up not making that data accessible for the other projects or initiatives? Thank you, Chair.
Okay, so thank you very much. I take it that there is no last hot question, because we're covering We're closing. Okay. I take note of Andrew, but make it half a quarter minute, a few seconds.
Quarters. All right. Thank you to all presenters. I think key challenge in almost all countries is data quality, and I haven't seen any comment or initiative to work on data quality. All countries are using DHIS2. I'm not sure how we are working as a network to improve the data that countries rely upon. Maybe Catherine will be a better candidate to respond to that. Thank you.
And lastly, the partner behind. Just 2 seconds.
So my question was, I think everyone's used DHIS2, and as a DHIS2 expert, I've seen people work with quantitative data in DHIS2. How are we thinking about qualitative data collection, semi-structured guides? How do we sort of take that into DHIS2 because it also allows doing that, or other tools to be able to standardize qualitative data?
Thank you very much. I think we stop there and we then get the responses. We shall continue with the conversation in the smaller groups. Let's begin from my left, then we'll conclude with the Bangladesh.
Merci. La Côte d'Ivoire n'a pas eu de questions particulières, mais je profite pour signaler que le système d'information sanitaire en Côte d'Ivoire ressemble à beaucoup d'autres systèmes. On commence par la périphérie, la collecte est faite au niveau des structures périphériques et remonte aux 3 niveaux du système de santé. Donc on peut vous décrire le système d'information sanitaire. Pour ce qui est de la qualité des données collectées par plusieurs partenaires, par exemple, chez nous il y a des rencontres régulières sur la qualité des données. Donc des rencontres périodiques sont faites avec tous les programmes impliqués pour analyser les données et valider les données. C'est cela que quand les données doivent être diffusées, on attend toujours que le pays diffuse officiellement les données. C'est pour vérifier la qualité. Pour ce qui est de la santé de la mer, nous avons 2 types de collecte d'informations. Il y a la collecte mensuelle qui concerne les données de routine, comme le montre sur le scorecard pour la performance des informations. Et il y a la collecte hebdomadaire qui concerne la surveillance des décès maternels qui est intégrée à la SIMR. Et à ce niveau aussi, il y a des analyses qui sont faites périodiquement. Voilà ce que je pourrais dire pour la qualité des données. Pour ce qui concerne les défis de paiement ou de motivation des responsables, en général, les données sont intégrées, font partie des services à offrir dans les structures. Donc le personnel n'est pas payé. Mais c'est vrai qu'il y a d'autres organisations qui soutiennent de temps en temps et ça entraîne le défi de la pérennisation. Merci.
Thank you very much. Dr. Finas.
Thank you, Mr. Chair. From Tanzania, we also face a challenge of data collection by different partners, whereby we find different partners have different tools for data collection, and that's in fact a big burden to the healthcare workers who are collecting data. But what we are doing, we are encouraging all partners through our technical working groups that they should use the approved national data tools for data collection, so that we can have one data tool which can collect data. And the other challenge about the data quality, I also face the challenge whereby the DHIS2, it collects data which has somehow low quality. As you may find the maternal mortality data, for example, having the age extremities of under 5 being reported as maternal mortality, or the male counts being reported as maternal mortality. What we are doing, we are just making the system to be smart enough and not to allow the person who is entering the data to make such mistakes. And we encourage the data system which are being used by the private hospitals and other organizations to be integrating with the national data warehouse. About the quality of data from the DHS2, I think I cannot comment on that. Thank you, Chair.
Thank you very much. And then finally, Bangladesh. I know you received many concerns, but summarize in,
okay.
in 1 minute. Just summarize. Thank you.
Okay, thank you for your keen observation. Regarding community level, one respondent, one participant has asked about how data is generated, collected. In my country, the community level, basically data are collected from the two sets of health workers. One group are working in the health side and other group working in the family planning side. The two group of health workers collecting data from the field side, and they are updating the data by using the tabs, application in the tabs in the community clinic. And by the community clinic service provider uploading the data in DHIS2. So this is this way the data is collected from the community level to the central level. And another issue was the another participant asked regarding the tertiary level status of DHIS2 and other activities. So in fact, still we are in progress for tertiary level DHIS2 activities, and at the same time we are still progress in automation in the tertiary level and specialized hospital. But at the district level are fully covered by DHIS2 data system. So in the district level, we are regularly generating data in the dashboard and taking measure by seeing the data, by seeing the performance of the service provider in the dashboard. And regarding the experience of care, we are regularly conducted a periodic survey of patient satisfaction survey. After getting the survey result, we are taking measure accordingly in the facility to address the specific challenges. Definitely, finally, the data quality is the still challenge in our country. So we are taking several measures to address the data quality by cross-checking, by data introduce the data supervision and other related activities that in this way would be able to address the proper quality of data and ensure that right data are coming from the field side and the evidence will be generated correctly for taking the necessary measure. Thank you, everybody.
Thank you very much. We'll get the rest in the small groups. Just to conclude this session, let me allow 1 minute to be shared between the two experts who provided the reflections, if you have anything to add. Okay, so you give 1 whole minute to Kathleen for your last comments.
Thank you very much. I just wanted to just share in terms of the network monitoring technical working group, and I'd like to acknowledge Dr. Moise Muzigaba, who's here, who's the focal point within the WHO Geneva team, and Deborah Jackson, who's the co-chair with WHO, and myself. A lot of these themes that are coming out, we're really thinking very intensively about and developing some materials that can help countries learn from each other. For example, the data quality. You know, that's a huge issue, and we're all struggling with it. And we have some great examples from, for example, Ghana, as well as we've heard from Dr. Hema Magi about some of the work going on in Ethiopia, very systematically actually applying QI to improve quality of data, understanding what the underlying contributors are to poor quality of data, and addressing those just like we would with any QI measure. So we'll be making every effort to sort of synthesize some of this learning, share some of the tools. I also just wanted to briefly respond to the colleague who asked the question about qualitative data, and I really appreciated that question because I think for experience of care, we heard the example from Bangladesh of patient complaints. We also have just in January published in the Lancet Global Health a 3-country study that validated a short person-centered maternity care scale that asks 13 questions that really gets at positive and negative experience of care, and I think that can be very promising for us if people are interested. I'm glad to share that resource, and I think to be able to triangulate that with occasional qualitative data, because we know we also need to listen to people's experience beyond just quantitative scales, and that's where I think partnerships with universities can be really beneficial for us to build those skills in country. Thank you.
Thank you very much, Catherine. Okay, so as we conclude this session, I think the session has been useful to demonstrate the fact that we need to pay a lot of attention in this area. Because for us to demonstrate that this works, we need data and good data. And yet we have the other aspect of experience of care, which we are not yet very good at, as you've seen in many countries. So there's a lot of work we have to do there to see how we can get qualitative evidence and move away from just sharing stories, because people will ask evidence. And to give evidence, you must have data, not just a story that this is how we did, but show the figures. The statistics speak better. So let me allow my big chair to conclude this session, and then we break. Thank you.
Thank you very much, Co-Chair. I think in summary, what has really come up very critically is that, quality data is critical for us to improve quality of care. But then the quality data does not happen automatically by deploying some electronic system. It's a conscious effort of quality improvement also of the data, so that there need to be systems that you put in place to improve the data. And I think that has come up from all. And then also the whole issue of the visibility, availability, and the use of the data has also been shown by all the presenters. And then the critical issue of going forward, looking at some qualitative data, especially when it comes to the patient experience of care. And in all, I think all the panelists, so let's give them, all the panelists, a round of applause for a very good presentation, and I think we've learned quite a lot from them. Thank you very much.
Thank you. Now, we're going for break, but Secretariat has
instructions, yes.
Yes, some guidance to give to help us in the next breakaway sessions.
Okay. So panelists, you are dismissed. Thank you.
Thank you.
Hi everyone, I don't want to stand between you and the coffee break, so I want to make this quick. We just have a few instructions regarding the working group sessions that will begin after coffee break. So we have 2 parallel working group sessions and a few short breaking changes. One moment, please.